All right. Good evening, everyone. A few minutes delay because of some technical glitches, but we are here for our grand rounds. And we're going to get promptly started just to make sure that everybody's been able to join in. All right. To get to our MOC and CME options, let me just go ahead and share with you my slides. Cardiology grand rounds for today are going to be hosted on the YouTube website, which has become extremely popular. And the CME credits for this session will be granted. You can text 25660 at 888-816-4893. And the MOC credits will be a link with the room code Future 2024. For answering the right questions, you get your MOC points directly going into your CME ABIM cloud profile. Once more, both MOC and CME credits for getting the MOC points, make sure that you do get your CME credits first as well. With that, I'm going to bring in our guest speaker for tonight. It's going to be nobody else than Dr. Maya Guglin, who's our section chief for advanced heart failure and also the program director of the incoming advanced heart failure fellowship program, which is going to be soon starting, hopefully in 2025. Dr. Guglin, in a very short period of time, I'm really excited and honored that she decided to come and join us. And our heart failure transplant program is really growing and making ripples in the southern half of our health system. Many of you know Dr. Guglin very well, but a few do not know that before her lead role as a heart failure transplant cardiologist, she has also been a director of the Echo Lab previously at a previous institute. And I got a feel of that over the last weekend when she was on she's a CCU attending, and she called me, hey, Dr. Sengupta, I think you read an echo on a patient, and what is the structure on the right atrium? And we went back and forth, and she was really very good in her observation and made me go back and rephrase my conclusion. So hats off to her for her clinical acumen. And also it makes one realize that even if you become a specialist, you always go and take a look at all the images yourself. So which is a very good practice. So Maya, I wanted to just personally thank you for your leadership and also for the kind of the structure and the program that you are setting us up for. It is very, very important for us to acknowledge that Dr. Guglin has established heart failure transplant programs at 3 other institutes previously. She was at University of Florida School of Medicine, University of Kentucky, and University of Indiana. She was also the chair of the ACC Heart Failure Transplant Committee up to last year. And currently, I think we are very lucky that the transplant program and the advanced heart failure program, including the mechanical circulatory support and the shock, has a really good mix of young, extremely talented upbringing individuals and very senior and seasoned leader like Dr. Guglin, who are going to create a major change in how we have participated in taking care of our advanced heart failure patient. And today, she's going to give us some renewed insights into the program and what it means for all of us in terms of getting new insights. With that, Maya, the floor is all yours.
Thank you, Partho, for this very kind introduction. Thanks for your involvement last weekend, because I was really puzzled by the structure, but I think you were right. It was just prominent Christo terminalis. which is good for the patient, much better than what I suggested. Do you guys see my presentation?
Yes, we look good.
So I decided to present the topic of evaluation for heart transplantation and left ventricular assist device, opening the black box. I often heard from referring physicians that when they send patients for transplant or VAD evaluation, they really feel they send the patient to some kind of black box. They have no idea. They have no idea what happens inside. And several months later, if they're lucky, they hear something like not a candidate for anything, and this is the end of the story. And this was great disappointment. So I want to spend the next hour trying to open this black box and to see what's behind the curtain. What is our process? What is our thinking? And how do we decide who is candidate for what or who is not a candidate? So I went to AI and asked to show me what opening the black box look like. So Grok from Twitter created this image, and ChatGPT created that image, which I liked much better. So we'll try to open this kind of black box and see what flies out, what kind of cogs and wheels and other gadgets. I'll start with the case. This is the patient who was referred to us for evaluation for advanced therapies like a couple of months ago. He's 41 years old. He's a diabetic with poor compensation. HbA1c was 10.5. He has Charcot-Foot, open diabetic ulcers on one leg, not deep but open. Coronary artery disease with history of total occlusion of LAD and prior PCI on the LAD. Ischemic cardiomyopathy with ejection fraction 15%. Chronic kidney disease with the baseline creatinine of about 2. Obesity, BMI of 39. Obstructive sleep apnea on CPAP. Sustained VTE with multiple ICD shocks. Was admitted for cardiogenic shock. Was put on Impala 5.5. Had an episode of sepsis which was resolved on antibiotics. Suffered with acute ischemic stroke with minimal residuals. Had deteriorated renal function and was placed on CVVH, then on intermittent dialysis, and finally on 3 times a week dialysis. And we were asked to evaluate for advanced options. So I will ask you to speak up, everybody except for the heart failure section, because we all know this patient extremely well. So is he a candidate for transplant? Is he a candidate for VAD? He's on Impella 5.5. Is it end of life? He cannot be weaned. Like, what's the next step? What do we do for him? This is the reason I don't like virtual format. I cannot pick up on anyone. Sean, what do you think? Nobody thinks anything. Okay, so we'll continue and we'll go back to this presentation. So when we're faced with a question like this, we need to answer 3 sequential questions. Is transplant or VAD indicated? Are there contraindications? And then transplant or LVAD. So the first question, is it indicated? How do we approach this question? I'm sure that everybody heard a lot of times about this I need help abbreviation or acronym, where each letter stands for inotrope, advanced NYHA class, end organ dysfunction, low ejection fraction, defibrillator shocks, hospitalizations, edema or escalating diuretics, low blood pressure, and cannot uptitrate the meds. So if we apply this criteria to our patient, he's not on inotropes, but he's on Impella 5.5. He's class 4, no question, of NYHA. His kidneys are almost cooked, although he has diabetic nephropathy as well. Ejection fraction is low. He has defibrillator shocks. He's hospitalized. He does not have edema, but low blood pressure, yes. And of course, when somebody is on Impella, you cannot uptitrate any prognostic medications. So yes, he fits this profile. But it is actually unusual that somebody fits this profile so well. Usually you will see some features, but not all of them. And I'm showing it to you not because I don't think you know it. I'm sure you saw this many times. But to try to understand what's behind all these features. Inotropes, low blood pressure, cannot uptitrate the medications. I want to show you the progression of heart failure, and I will use pressure volume loops. I have to admit that I'm not the biggest fan of pressure volume loops. I typically study them for boards and then stop using them because I never found them that helpful. But in this particular case, I don't know better illustration to show what's happening with the heart failure. So the first diagram represents normal pressure volume loop. Mitral valve opens, left ventricle fills, end diastolic volume is normal, end diastolic pressure is normal, isovolumic contraction, aortic valve opens, systole, aortic valve closes, isovolumic relaxation, and the cycle repeats itself. And in the middle, the width of this structure is the stroke volume, which is normal. When we move to stage B, so structural changes but no symptoms, we have some increase in the end diastolic volume, but the rest is still normal. End diastolic pressure is normal, stroke volume is normal, systolic pressure is normal. Now we're in the symptomatic stage or stage C of heart failure, symptomatic class of NYHA. So we have that not only end diastolic volume is increased, left ventricular end diastolic pressure is increased. And this is the key. This is the key to the symptoms of heart failure. Because if you want to give the hemodynamic definition of heart failure, you will come up with the formula. Heart failure equals elevated left ventricular end diastolic pressure, period, end. There is no heart failure without elevated left ventricular end diastolic pressure. And at this point, you can use ACE inhibitors, beta blockers, ARNI, diuretics, aldactone, SGLT2, everything will be working, and the patients may be stabilized in this phase for months and years, and sometimes for decades. But then eventually all the compensatory mechanisms get exhausted, and we move to the final stage. When even at the cost of very high elevation of left ventricular end diastolic pressure, you cannot maintain normal stroke volume. Stroke volume is decreased, systolic blood pressure is decreased. It means that we move to the stage when congestion is no longer the dominant syndrome. The dominant syndrome is decreased cardiac output. And that's what separates advanced heart failure from any other heart failure, because it requires principally different therapies, principally different treatments. And that's when we can be of help to the rest of the world, because we can do these treatments. And unless we increase this decreased cardiac output, we are not going to be able to help this patient. And there are only three means to increase it. It is inotropes, LVAD, and transplant. Let's start with the inotropes. Inotropes do not have good publicity In fact, some people claim that they reduce longevity or increase mortality. But every single advanced heart failure in the country uses long-term inotropes. If they were increasing mortality, I mean, we would be doing something criminal. But we don't think so. We think that we're helping the patients. I can try to show you why we think highly about long-term inotropes. We talked about low output syndrome. So this is the definition: systolic blood pressure less than 90, cardiac index 2.2 or less, and wedge pressure above 15. Just to make sure that we are not falsely reading low output because patient is dehydrated. So wedge pressure should be slightly above normal range. Back to inotropes. This was the largest randomized controlled trial on milrinone versus no milrinone. It was not placebo control, it was yes or no milrinone. It was applied to hospitalized patients with decompensated heart failure, not necessarily in shock, just decompensated heart failure. Primary endpoints was the number of hospital days due to cardiovascular conditions at 60 days, and secondary endpoint was adverse events. So if you look at the primary endpoint, you see that control and milrinone provided exactly the same effect. There was no difference whatsoever. However, in terms of adverse events, milrinone provided much higher rate of adverse events. So again, we have best possible evidence randomized control trial, and nevertheless, we keep giving this medication that provides adverse events, and some of them, as you know, are as significant as atrial or ventricular arrhythmias. Why do we not believe these results? The key to my mind, and it is my personal opinion, it is if you look at the inclusion and exclusion criteria of this trial. So exclusion criteria: patients were ineligible to inclusion if their systolic blood pressure was below 80, if their creatinine was above 3, and this is the key: if the treatment physician judged that the intravenous inotropic therapy was essential. Just think about it. We excluded all patients for whom their physicians thought milrinone was essential from inclusion in this trial. So we basically removed any opportunity for milrinone to show its beneficial effect. But certainly all side effects or adverse events could be displayed to full degree, to full extent. And this explains the results of this trial. No benefit in terms of direct effect because there was no right substrate. Patients were not with low output because they were in the compensated heart failure. And we do not apply inotropes to decompensated heart failure. They increased cardiac output. So this is the only subset of patients to which they should be applied. But we received increased adverse events. So that's why we find that inotropes can help patients to a great extent, and we use it a lot. So this is from yesterday, from my last weekend on call as CCU attendant. So we had this patient who was admitted with decompensated heart failure, and his baseline hemodynamics showed right atrial pressure of 20, pulmonary arterial pressure 52/25, wedge of 25, and cardiac index 1.5 and 1.7 by peak and turbo dilution respectively, and PA-SAT was low. We started on milrinone, and right atrium decreased to 2, PA systolic 37, diastolic of 12, wedge of 14, and cardiac index and cardiac by both methods 2.7 and 2.9. You may say that we also diuresed the patients, and that's why his filling pressure is normalized. Yes, of course. But then we said to patients that we likely discharge him on home Milrinone. And he said, no, I don't want anything attached to my body. And we said, okay, we will give it a try. We'll wean you off Milrinone and see how you do without it. So off Milrinone, one night or 12 hours later, we see that right atrial pressure of 9, pulmonary artery systolic is back to 47, wedge is back to 18, and cardiac index is back to 2 and 2.1. And we didn't change anything else in treatment. It was pure inotrope withdrawal. So we showed it to him, and we said that we cannot discharge him of Milrinone because he will not last long without hospital. And we put him back on. And we saw again 12 hours later, right atrial was 0. You see decrease in pulmonary artery systolic and diastolic and the wedge, and increase in cardiac output. That's what Milrinone does in end-stage heart failure when it is truly indicated. Patients literally cannot survive without it. Wdn or Milrinone. This is head-to-head comparison. And if you see on this delta column, you see that you see how much which parameter was reduced on the butamine versus Milrinone. So pulmonary artery diastolic pressure was decreased from 31 to 22 on the butamine, from 31 to 19 on Milrinone. Difference was 31 on the butamine, 36 on Milrinone. Difference in favor of Milrinone. Mean pulmonary artery pressure, minus 28 the butamine, minus 35 Milrinone. And this is true for all parameters. And that's why we prefer Milrinone to the butamine. As an extra benefit, you cannot use beta blocker with the butamine because they counteract, but you can use beta blocker with Milrinone. And Milrinone is causing much less tachycardia, less arrhythmia, and it is a selective pulmonary vasodilator. That's why it is our medication of preference when it comes to inotropes. But let's see, we show that the patient has low output. Does it necessarily mean that they are candidates for transplant or LVAD? No, it doesn't, because we need to check whether there are any reversible conditions we can potentially use to reverse their heart failure, left ventricular dysfunction, and make them viable again. What kind of conditions it is? It is tachycardia-induced cardiomyopathy, as you see the piece of EKG with atrial fibrillation. It is severe coronary artery disease. Multi-vessel coronary artery disease can be fixed by either CABG or stent with subsequent increase in systolic function. Mitral regurgitation, if it is severe, can be reversing the heart failure. Left bundle branch block or pacemaker-induced cardiomyopathy, you can use bundle pacing or CRT to reverse this cardiomyopathy. Frequent PVCs, as you see by Gemini, or severe aortic valve stenosis, as you see over here. Intervention on all of this condition can dramatically improve the course of heart failure, and patients will not need any advanced options at all because their cardiac output will increase and they will no longer have low output syndrome. Mitral regurgitation is a special condition, and I want to spend some time talking about this. When this diagram was built, the comparison was made in relative decrease in mortality with introduction of different means of treatment of advanced heart failure. And you see by how much mortality was decreased, it was relative decrease with ASO-ARBs to greater extent by Entresto, to greater extent by beta blockers, and so on and so forth. But the greatest impact was made by MitraClip. So we all need to think differently. We all need to shift the paradigm in our thinking primarily because we always considered mitral regurgitation just another comorbidity. Left ventricle gets dilated, annulus gets dilated, and there is severe mitral regurgitation. But now we have the means to treat it as a separate condition, and it may be very worth talking, very worth doing. So this was the co-opt trial, we showed for the first time that mitral repair with mitral clip with catheter actually creates mortality benefit. Less people or fewer people die from it. Very recently, literally 1 month ago, in London, there was a presentation of the Reshape HF2 trial, when same strategy of MitraClip was applied to people with not severe, but moderate to severe mitral regurgitation. Just to give you an idea, in this trial, mean effective regurgitant orifice area was 0.25 centimeters. Only 14% met the classic definition of severe mitral regurgitation with mean ERO of greater than 0.4 square centimeters. And almost 1/4 of the patients had ERO of less than 0.2 square centimeters. So they randomized patients into age-to-age repair with MitraClip plus guideline-directed medical therapy versus guideline-directed medical therapy per se. And one of the outcomes was the composite of heart failure hospitalizations or cardiovascular death at 24 months. So in the MitraClip arm, the events were 37 per 100 patient years. In the medical therapy arm, it was almost double of that, with 59 events per 100 patients years, with highly significant difference with p-value of 0.002. There was also equally significant improvement in the quality of life score in the mitral repair arm. If you look at the results of these trials, you see that the curve starts separating almost immediately. By 3 months, they're already quite separated. And the longer the trial goes, for 2 years, the greater the separation is. So this is composite of hospitalization for heart failure or death from cardiovascular causes. And the second graph reflects hospitalizations for heart failure. So when you see severe mitral regurgitation, or now even moderate to severe mitral regurgitation, perhaps we can delay the evaluation for transplant LVADs by God knows how much time. It really, really helps. Besides this reversible condition that we can fix, there are a number of conditions that can improve on its own or with some supportive treatments. Let's list these conditions. Acute myocarditis, Takotsubo cardiomyopathy, or same condition, neurogenic stunt myocardium or pheochromocytoma, hyper or hypothyroidism, alcoholic or meth-induced cardiomyopathy, peripartum cardiomyopathy, just idiopathic non-ischemic cardiomyopathy in young women. All of this condition can reverse spontaneously or with treatment if we just support them for several weeks or several months. And if we suspect that this is the primary cause of the advanced heart failure, we really should not rush to transplant or LVAD because both of these options are irreversible. Transplant and LVAD are irreversible steps. They change patients' prognosis and their life forever. So if we can do anything at all to try to avoid it and to create them a reasonable quality and quantity of life, probably we should do that before jumping to transplant or LVAD options. Is it a necessary condition to have low cardiac output to offer cardiac transplant? No, there is exception to another end as well. What are they? Hypertrophic cardiomyopathy, cardiac amyloidosis, VT storm that cannot be controlled by other means, cardiac sarcoidosis if it results in low ejection fraction, many forms of adult congenital heart disease, some benign cardiac tumors, coronary artery disease with no revascularization options. So even with the normal or slightly decreased ejection fraction, or even with the hyperdynamic ejection fraction, hyperdynamic, these patients can be considered candidate not for VAD, but for transplant. And sometimes for VAD as an intermediate option. So this is the exception. So once we established that patients is in the end stage of heart failure, which is predominantly low cardiac output syndrome, and there are no reversible conditions or other means to repair the heart without something as dramatic as LVAD or transplant, then we proceed to our second question. Are there contraindications? So what are the contraindications? If we consider heart transplant, severe COPD when the patient is bound with the high flow or home oxygen and they cannot walk because of shortness of breath, they're not going to improve if you give them new heart. Some systemic illness, really systemic illness, like systemic scleroderma with multi organ failure, like difficulty swallowing, sclerodactyly, other systemic manifestations. But you know, it requires some exploration because, for example, systemic lupus may not be contraindication for transplant because after all, it is treated with immunosuppression and that's the treatment for transplanted heart. So we may be able to help. Malignancy with poor prognosis, liver cirrhosis. So liver cirrhosis is usually hard stop for any evaluation for transplant and LVAD. We won't be able to help. We won't be able to do anything. And because it is a hard stop, we need to first make sure that we are truly dealing with cirrhosis with portal hypertension, not with the high-grade fibrosis, for example. And therefore, we usually prefer to do a liver biopsy if there is any doubt about finality, advanced stage of the cirrhosis. That's what we typically do. Dementia or severe psychiatric illnesses, severe pulmonary hypertension. So a couple of items I want to spend a couple more minutes to elaborate on them. Malignancy with poor prognosis. So recently it was a very uniform definition. If you are cured from malignancy, if you are on remission or you're cured, we have to wait at least 5 years before we consider transplant because immunosuppressive medications will stimulate the growth of any malignancy and put the patients at high risk of dying of cancer and therefore will cancel the results of heart transplant and we will waste the organ and without helping the patient. Recently, the guidelines changed. They changed to much more detailed description, and this is hot of the press 2024 guidelines. Just as an example, what is recommended now? For example, breast cancer. If it is stage 1, we can proceed with transplant with no additional waiting time. If it is stage 2, if they're in remission for 1 to 2 years, we can proceed to transplant. Stage 3, it is 3 or 5 years after consult with oncology, and only stage 4 is not eligible for transplantation. History of colon cancer. Again, you see multiple stages like tumor, nodules, metastasis, and the time we need to wait till we decide to put the patients on transplant list. Again, between 1 year to 3 years, and only advanced stages require 5 years of waiting after the patient is in remission. So please don't think if there is a recent history of cancer, it automatically means that they are not a candidate for even heart transplant. And they certainly can be candidate for LVAD. We may be able to help these patients because we will need to go by this detailed guidelines, consult oncology, and perhaps find some acceptable option for them. Pulmonary hypertension is another condition worth discussion. So there are a couple of stages of pulmonary hypertension in heart failure. The early stage, we can call it hydrostatic stage. Basically, like we said, the heart failure is increased left ventricular and diastolic pressure. And in diastole, it means increased left atrial pressure, increased pulmonary venous pressure, increased pulmonary artery diastolic pressure, because it is all same column of fluid with the same pressure. It means that if we normalize the wage pressure or left ventricular and diastolic pressure, pulmonary hypertension will disappear. However, if we wait long enough and don't intervene in this stage and don't keep people euvolemic or optivolemic, it will move to the next stage when there will be vasoconstriction of the pulmonary vasculature and eventually remodeling of the pulmonary vasculature. And it will keep the pulmonary pressures elevated even if we remove the heart completely and put a new heart with the totally normal filling pressures. Pulmonary pressure will remain high because there will be no time to reverse remodeling of pulmonary vasculature, and the new unconditioned right ventricle will fail because, as you know, right-sided chamber, right ventricle, is not created to withstand pressure. It can handle the volume overload, but not pressure overload. And that's why when the pulmonary vascular resistance is above 3 Wood units, we typically would not do transplant. While they're in the hydrostatic stage, it is much easier to intervene and adjust diuretics or other treatments. That's why I put such a great effort in making sure that we launch the CardioMEMS program, which is currently approved, and we are scheduling patients. Because this option was not available at this hospital previously, I will briefly go over CardioMEMS. So this is the device looking like a dragonfly. With this is the sensor. It doesn't have any battery. It is implanted in the pulmonary artery. This anchors just hold it in place. That's what the actual size of the sensor itself. It stays in the pulmonary artery forever. You never change it. It just catches the oscillation from external electromagnetic field, but it doesn't have any energy source on its own. So this device is implanted in the pulmonary artery with the simple procedure like right heart cath, like Swan-Ganz catheter. This is the pillow which is given to the patients like a wedge pillow. They lay on the pillow and capture the signal, press this button, and via the internet it is transmitted to us to a special system where we can read their pulmonary pressure. The screen looks like this, and it is pulmonary systolic pressure, pulmonary diastolic pressure, and pulmonary mean pressure. And you can also mark the screen like when it was recorded and what changes were done at this particular date. So once a month, you get all these things summarized in the note in the chart. And you see when the signal was taken, what was pulmonary artery systolic, was put PE diastolic, pulmonary artery mean, what was the heart rate, whether hospitalizations occurred or what other events occurred during this time interval, or in the past in this patient in general. And as you see, this is the patient with LVAD, and probably that's why all his pressures are remarkably stable. So likely the CardioMEMS was implanted before the LVAD. This is the results of several trials, both randomized and community studies, post-approval studies on CardioMEMS. This is the title of the study, and this is the absolute, not relative, absolute reduction in heart failure hospitalizations. 28%, 33%, 24%. This is last two lines are remarkable because those are post-approval studies which typically provide less difference, less significance than much more purified and tightly regulated and controlled randomized controlled trials. But as you see, in both European and United States post-approval studies, the absolute reduction in heart failure admissions were 62% and 57% respectively. It is huge. And since there is such a big desire, such a big goal to reduce heart failure readmission, we think that getting CardioMEMS up and running is going to be one of the major tools, but only if it is used. Because what I saw time and time again, only heart failure patients refer for CardioMEMS. Internal medicine physicians, general cardiology, for some reason, don't refer this actively. And the indications only include one admission for the last 12 months, in the last 12 months, or elevated BNP or NT-proBNP. So any frequent flyer, I would say 2 admissions in a year, without gross negligence or non-compliance, should be considered for CardioMEMS. Let's look at this curve. So this is systolic mean and diastolic pressure of patients who I managed back in 2017 with CardioMEMS, as you see, with severe pulmonary hypertension due to heart failure. So we did multiple interventions and we could not decrease the pressures. They remained between 80 and 190 all the time. And then something was done. And all of a sudden, all these numbers dropped to almost normal levels. What was done? Please speak up.
LVAD?
LVAD. So there is no better treatment for pulmonary hypertension due to heart failure than LVAD. Implantation of the LVAD, that's how dramatically it can decrease pulmonary pressure. That's why when we have severe pulmonary hypertension, LVAD may be a bridge to transplant because it may be used to decrease pulmonary pressure. By the same token, if LVAD can be used for this purpose, why other mechanical circulatory support cannot? Can Impeller 5.5 be used? Why not? If the change is so quick, maybe several weeks on Impeller 5.5 would be enough for bridging the patient to transplant. And here we move to the final question which we ask when we consider the patients for transplant or LVAD. Transplant or LVAD, how do we choose? So I just showed you one criteria. Pulmonary hypertension is the contraindication for heart transplant, but not for the LVAD. What about other conditions? So let's go over other indications which are relative and not absolute. Age. For the transplant, the age is 70. We still can consider patients with no comorbidities 71 or 72, but typically we won't move beyond that. With LVAD, there is no limit. Although when you get closer to 80, they typically do not tolerate LVAD well. But still, you have another decade when you can still intervene. Obesity. For heart failure, the cutoff is 35. For LVAD, there is no cutoff. Sky is the limit. It's 40, 50, 60, whatever you want. Renal impairment, only if it is not due to cardiorenal syndrome, and also it is relative contraindication. We just discussed the cancer, but with LVAD, the criteria are even softer than for transplant, because LVAD does not require immunosuppression. So the only question is, what is the prognosis of this cancer? How many years does the patient have? If it is 2 or 3 years, LVAD may be a reasonable solution. HIV, only if it is AIDS. If it is low CD4 count and patient is on therapy, no contraindication for either transplant or LVAD. Psychosocial, all these support systems, all these narcotics, illicit drugs, presence of supportive family, compliance, and so on. All of this is relative. Several years ago, I listened to one presentation. It was a survey of United States LVAD implanting programs. The question was, how do programs approach the patient who uses either tobacco products or marijuana? So this was the span of the answers. Require abstinence from cannabis but not tobacco, 11%. Require abstinence from tobacco but not cannabis, 2%. Abstinence from both, 42%. Do not require abstinence from either, 38%. Don't ask, don't tell, 6%. So basically, it is very flexible, it is very program dependent, and it just shows you how relative these relative contraindications are. Many of them can be overcome. So other conditions. So this is LVAD. Takes the blood from the apex of the left ventricle, pumps it into the ascending aorta, assisting the left ventricle. What does it do to the right ventricle? So this is 3D echo reconstruction. What it shows on the left side is left ventricle, left ventricular volume. You see two contours. So the bigger, larger external contour is on low speed LVAD support. When you spin the VAD, when you run the VAD faster and faster, the left ventricle shrinks because it is getting progressively unloaded. So the volume decreases. At the same time, on the right side, if you look at the right ventricle, this same increase in the speed of LVAD does exactly the opposite. The inner contour is on lowest revolutions per minute, and the larger the outer contour is on highest revolutions per minute. So the higher the speed of the LVAD, the more we compromise the right ventricle. That's why we're so concerned about right ventricular failure on left ventricular assist device. That's why we're trying to evaluate the right ventricle so closely before the decision is made to implant the LVAD. And if you look historically, what kind of metrics were applied, you will see that all of them are not much better than flipping the coin. So area under the curve is not really great. So the current view, the current standpoint, we mostly go by these parameters. Central venous pressure to wedge greater than 0.6, or diameter or size of right ventricle to left ventricle greater than 0.75, or right ventricular stroke work index, which is difficult to calculate, that's why we don't. And PAPI is the current favorite, which is pulmonary artery systolic pressure minus pulmonary artery diastolic pressure divided by central venous pressure. And if it is less than 2, the surgeons will typically want to implant LVAD because the odds of right ventricular failure are too high. And we don't have good means to treat right ventricular failure. So we better optimize the patients before they implant. How to optimize them? Increase the difference between systolic and diastolic pulmonary pressure, and most importantly, decrease central venous pressure, diurese the patients to their dry weight, decrease the CVP, and therefore the product will be much more favorable, and the right ventricle would tolerate the surgery much better. And if you are unable to do it, if the right ventricle is so far gone that you cannot increase PAPI or decrease the CVP, it probably means that LVAD is not a good option. What about longevity? That's how much the field has advanced since the beginning of the century. You see that with the historically first type of LVAD, which was 2001, HeartMate XVE, the survival at 24 months was 24%. So basically 80% of people were dead by the end of 2 years. You don't see it here, but on BEST, guideline-directed medical therapy, everybody in this group was dead by 12 months. So LVAD, even in this first generation, was much better than medical therapy. And you see the progress moving from VAD to VAD. Survival at 2 years was 60, 68, 76%. And finally, with the currently available HeartMate 3, survival at 2 years is 83%. Survival at 2 years with heart transplant is 82%. It is similar. So up to 2 years, survival is similar, although quality of life is still better with the transplant because admissions are much more frequent with LVADs than with the transplant. What's the survival with the transplant? It is also limited. This is just one example. Survival at 26 years post-transplant is 10%. But nevertheless, for example, at 5 years with the modern LVADs, people survive like 65% of them. With transplant, as you see here, 70-something%. So even at 5 years, the difference is no longer dramatic. The median survival with HeartMate 3 is 7 to 8 years. And because, as you see, the survival with transplant is finite as well, there is an argument among specialists in the field, should we implant the VAD first, get 5 to 7 years out of it, and only then transplant the heart, because the median survival with the transplanted heart is about 15 years. If you are 69 when you get your heart transplant, then it is not so bad. But if you are 35 or even 50, you really don't want to die when you're 50 or even 65. So maybe several years VOD by VAD is not such a bad idea. Also, I wanted to show you, because not many people appreciate how much work gets into listing somebody for heart transplant. Like, for example, many of you know that if we use mechanical circulatory support, even such simple as balloon pump, we can list the patient in quite high status 2. For reference, the highest status is 1, but this is almost impossible because this requires that the patient is on ECMO, VA ECMO. So status 2 is really the highest, more or less commonly used status. So balloon pump by itself is not enough to list the patients in this high status. Those are the conditions we have to meet. Within 7 days prior to balloon pump implantation, all of the following should be true within one 24-hour period. Systolic blood pressure less than 90, wedge above 15, cardiac index less than 1.8 of inotropes or less than 2.2 on inotropes. And this is good only for 14 days. If in 14 days you did not transplant this patient, you have to meet all similar criteria again in order for the status to be extended. Otherwise, you lose the priority and you have to downgrade the patient to a lower status. That's why we use right heart cath so extensively. That's why it is so difficult to really transplant somebody. And by the way, last week we transplanted our 10th patient in this calendar year, and the patient is doing well. So this is our algorithm. Patients may be eligible for transplant or LVAD and donor is available, or eligible for transplant only, then you transplant. If it is right ventricular failure, restrictive cardiomyopathy, small ventricle, you cannot use LVAD, you use transplant. If the patient is eligible for transplant or LVAD, but they have to wait too long for a donor, then we list them for transplant, but implant the LVAD. Patients may be too unstable to wait, or he may be of large body size, blood type, or and so on. So they really cannot wait to transplant. So LVAD is an option, and that's why we almost always evaluate simultaneously for transplant or LVAD. Not eligible for transplant, eligible for LVAD, but may become transplant candidate in the future as a bridge. Severe pulmonary hypertension, questionable compliance or psychosocial status, recent substance use but wants to quit, recent malignancy with favorable prognosis, or like we said, relatively high body mass index. Finally, not eligible for transplant and eligible for LVAD, then we implant LVAD if the patient is too old for transplant or their prohibitive comorbidities. So the patient with the Charcot foot, decompensated diabetes, and high HbA1c, obesity, obstructive sleep apnea, and of permanent dialysis, we basically implanted the LVAD and he is doing well. So all these conditions are relative contraindications. We would consider the patients. He is 41, so we would try to give them chance to live. And my final message, nothing is absolute in our field. For example, David Rockefeller died at the age of 101 after his 7th heart transplant. So everything is possible. Thank you very much for your attention. I will take questions.
Thank you very much, Maya, for a great comprehensive overview. We will open up a discussion. A couple of thoughts that I have in my mind is when is it too late for a referral to an advanced heart failure group? Or in other words, let me rephrase it. When should a patient be referred? Because I think we are having lots of patients who have MIs or who have, who are at risk of developing advanced heart failure. What is the right time advanced heart failure group should see them? Should they be seen at least once when they have not really gone and become an advanced failure? Or should we wait for them to have heart failure? I just wanted to your viewpoint.
Partner, it's totally reasonable. It's a great question because, after all, that's what triggers everything, right? That's what it is about, like when to refer. Again, I did the CCU last week, and we had a patient post-STEMI in the LAD territory who ended up with ejection fraction of 10%. So I gave it to our group and will schedule him in clinic to be seen. He has 0 symptoms. He is completely euphoric because he doesn't have pain and everything is great. But I know that as soon as he starts doing some activity, he will be symptomatic. So why to wait? It is a scar. It is not going to recover. So once we are trying to up-titrate guideline-directed medical therapy, I think we should be following him. If they have already established cardiologists, we are happy to co-manage the patient. even not co-manage. We don't really want to intervene in the management, but they can see their usual cardiologist as often as they want to see, but us every 3 months or every 6 months, whatever is indicated, so that we don't lose them, because nobody knows when they're going to crash. And evaluation process is also not an overnight process. We need to screen for all kinds of infections, for all kinds of malignancies, colonoscopy, CAT scan, pulmonary function tests, this and that. So it takes time. And if we find something, we're down the rabbit hole exploring this condition. So it may, for example, some nodule in the lung cannot be biopsied, repeat CAT scan in 3 months, right? So we're waiting for 3 months. Will the patient survive this 3 months or not? I have no idea. Nobody knows, because we don't have the crystal ball. Everybody is unique. So I think if you see low ejection fraction which is not recovering, and even if the patient does not have symptoms, at least run them by us. Not necessarily like send to clinic. Just catch us somewhere, let us review the chart and see what we think. We may be able to offer something.
Yeah, and Maya, I think you make a very strong point. I certainly feel like our STEMI program, once we are revascularizing, I mean, I think over time, many LV recover, but many will not recover. And then to fit them and lose the chance for them not to be part of a good program that could offer, I think could be a mistake. I mean, I think we might have to redefine of how we are risk stratifying these patients, perhaps either using advanced imaging. Like, I mean, if it's completely scarred out, it's not going to recover, right? I mean, maybe an early risk stratification to why do you? I mean, that's another question that I have, is that with we are not using as much of MRI, to my knowledge, to restratify post-infarct scar burden and things like that. Maybe this is something should be offered, particularly for young infarcts, people who are, I mean, I see Southeast Asian community people coming here at 50, early 50 patients, large interval infarction, and we routinely are not doing viability assessment, and we wait for the LV to recover and wait for EF not to recover, and then they get an ICD. Perhaps the paradigm needs to shift a little bit, and we need to rethink about how do we offer some, particularly that is a group of people where with the emerging new therapies, perhaps it's very easy to lose these people in the crowd. And then they come very late. I worry a little bit about that, and maybe we need to think about an early stratification strategy. In the same way, I think I mean I also want to ask phenotypic advanced disease, right? Sometimes they're asymptomatic, but that they're going to progress. There are some group of people, maybe dilated cardiomyopathy, or as you mentioned, maybe we need to capture these people earlier, even before they have heart failure or they're coming up in the emergency rooms. That's too late, in my opinion. I mean, they should have been managed differently and could have been seen differently and done differently. And but we wait for them to have one emergency or two emergency room visits before we really do any workup. So that paradigm, in my opinion, needs to change now, with you all are being so aggressive in pursuing these people.
There is another component, Partha, psychological component. People need some time to process and to get used to the idea that heart transplant or LVAD may be some option in the future. Because if they're treated, and this is never mentioned, and they're completely unprepared, and you drop this on their head, they recoil, who wants that?
Yeah.
And they said, no, I don't want anything like this. And then they go away, and then it is too late.
Yeah, and Maya, also I feel like on the same plane, I'm not saying that we should rush in. I think we also delay the inevitable and some patients, obviously there is, you need to just bring in an early discussion with the family on the goals of the care. that also we have seen, we struggle a little bit, and it's only in the hospital pressured environment and the family is discussing that. It should be in a completely outpatient setting. I think they will be more better prepared to understand, and maybe they will get it after 1 or 2 visits. But it's too pressured environment for them to be able to discuss the goals of care. And some people may not want anything. Maybe we need to just be very careful about. Anyway, there's a lot to discuss about, and there are additional questions that should come. Dr. Sasha East is asking a question. Great presentation. How do you approach pseudo severe aortic stenosis in patients with significant LV dysfunction? Do you consider replacing the aortic valve before more advanced therapies?
Absolutely. Well, how do I approach it with low dose dobutamine stress echo? Well, probably like everybody else. But you know, replacement of severely stenotic aortic valve can do wonders on ejection fraction.
Yes.
People literally can jump from 20 to 40% within the same admission. So I would not go for transplant for LVAD unless they're so far gone that you want to put some kind of mechanical device to support them and to do TAVR. And of course, you cannot do it with impellers, so probably LVAD is an option. But then be prepared to remove the LVAD or to isolate the LVAD if the ejection fraction recovers, because aortic valve replacement is extremely favorable substrate for recovery of ejection fraction. Even if it is like less than 20%, they may recover.
Yeah. Dr. Maganti is asking, thank you for a great lecture. I have 2 questions. We have set of predictors to utilize patients who progress from stage B, C, D. Apart from GDMT and LVAD, do we do more genetic testing? Do we have set of predictors to utilize for predicting patients who will progress from B to D? Are there any known predictors?
Not really. I mean, it is common sense. If there is familial cardiomyopathy and they have a brother who had transplant and father who dies suddenly, then of course we're going to be more aggressive with these people because we will know that they will likely not recover and progress to terminal phase. So we currently have one of such patients in hospital on Impella 5.5 waiting for transplant in status 2. If they are ischemic, non-ischemics may recover. Ischemics, if it is a large scar, like large proximal or ostial LAD with transmural infarct, they will not recover. So this is a predictor of rapid progression. If they presented with the cardiogenic shock once, it means that basically their reserves are very, very thin and we better move quickly, otherwise we'll lose them.
Thank you. I think there was a comment also, do we do more, when do you do more genetic testings, or maybe in familial, or as you're mentioning, or do you think there's a role?
Yeah, I mean, the role, of course, because we want to know, especially for screening family members. But in terms of management, it is almost irrelevant because you treat them exactly similarly to other patients, exactly the same.
But it may be probably more informative for the patient's familial discussions.
Exactly, so that we don't forget to screen their teenager children or grandchildren or whatever.
Yeah, great. And Dr. Barrett, thanks for joining, Connor. Thanks for an outstanding presentation. Can you comment on the role of post-transplant surveillance and how this has changed or may change?
So the post-transplant surveillance is basically the surveillance for rejection and for post-transplant vasculopathy. Post-transplant vasculopathy is typically evaluated by either serial left heart cath or sometimes with stress tests, usually the dobutamine stress echo test. There are more advancements in terms of surveillance for rejection. Recently, it was considered that biopsy is a gold standard, and patients were biopsied like for 20 years if they were lucky enough to survive for 20 years, at least once a year. That is traumatic. It is traumatic for tricuspid valve. because multiple biotome back and forth with pieces of tissue, it can easily injure the leaflets of the tricuspid valve. So recently there was a discovery that there are methods, there are assays commercially available, FDA approved, to track donor-specific DNA in patient's blood. So it becomes a blood sample issue. And this cell-free DNA is very highly sensitive and specific for rejection, to the point that many are arguing that biopsy should no longer be called the gold standard for rejection diagnosis, because there is a better way to diagnose it as a cell-free DNA. So in our program currently, we only do 6 biopsies for the lifetime of the patients. And we are moving towards reducing it further to 4 biopsies for lifetime. In the beginning, with the last biopsy at 1 year post-transplant. And all the rest is going to be non-invasive monitoring, non-invasive surveillance with cell-free DNA.
Great. Maya, I know that it's late, but I want to just want you to comment upon your participation with Nevaeh Beth Israel on creating some combined educational and research opportunities. You have had recently some discussions. Would you like to just comment on that? Because I think in the next year, perhaps what we need to do is to create a combined grand rounds whenever these sessions happen, to bring in our colleagues from Nevaeh Beth Israel on the opportunity of not only the educational program, because what you're trying to do is a non-ACGME heart failure advanced program. They have a ACGME advanced heart failure program, but the 2 campuses will continue to collaborate very closely on many fronts. So would you like to comment, including our surgical colleagues who are interested to, but I think you have worked with some of the colleagues in Nevaeh Beth Israel. So would you like to comment upon that? Because that will be a very important message of how we as a health system can really make a big departure from what we have done in the past.
Absolutely. So there are several options. First option is participate in outside registry. We joined the AHA registry on cardiogenic shock, and we're in the process of joining the cardiogenic shock working group registry. And there is a possibility of some exploration of this thing. And as we're collecting the data, we ought to have our own database, so we can check some of our ideas on the smaller subset before jumping to like multi-institutional data set. There are smaller, there are large randomized controlled trials run by industry, this is something we're exploring. There are small startup companies with medical devices which approach us about participation in small-scale trials. We're actively exploring this. And finally, we can practice investigator-initiated trials. Of course, they have to be cheap because I can only fund them from my startup funds.
No, I think that's great. And I think, but I love the idea of you collaborating with our colleagues in the health system, because I think we want to become a differentiator in terms of research and academic productivity in the near future in heart failure sciences. And I think we will next year probably bring in some combined presentation together. With that note, thank you everyone for joining and for your participation. We look forward to your continued participation in the grand rounds in the future. And we are really excited about the program that is coming together. Thank you, everyone.